Chapter 6 is Composites, Glass Ionomers, and Compomers. What is a composite resin? Composite is a mixture of two or more materials. The composite resins are tooth-colored restorative materials that have become quite popular today, and their composition is an organic resin matrix. There are inorganic filler particles to give the composite strength. There is a silane coupling agent that kind of sticks all of these components together. There are initiators as well as accelerators that cause this to cure and set. And then the pigments are what give it color. So we're going to break each of those components down. The resin matrix is most commonly bis-GMA. There's another resin used called urethane dimethacrylate, but the bis-GMA is the most commonly used in our resin fillings. The filler particles that I mentioned are usually added for strength and handling control and to help reduce the shrinkage as the material cures. These particles are typically made of quartz, silica, or glass. The smaller the particles, the smoother the surface, the more lifelike the filling looks. The larger the particles, the stronger the surface is, but it's a little bit rougher and it's not as polishable. So if you were going to use the stronger, larger particles, you would probably want to use those where they don't show, like back on molar teeth, where they're going to have to withstand a lot of masticatory force. A coupling agent is silane, and that provides that strong bond between the fillers as well as the matrix. So I think of that coupling agent as the glue that kind of holds them all together. And then, like I said, the pigments are what is going to give our resin tooth color. Classifications of these composites is typically by their filler size. If they have those larger fillers, which we said were stronger, they're going to be called macro-filled composites. Micro-filled have a smaller filler. And then we've got these hybrids that they keep coming out with, and that's why our composites look so lifelike and sometimes are so hard to detect, because they're getting so great with these fillers that give them strength but also make them look very lifelike. So the hybrid composites are micro hybrids, nano hybrids, there's universal composites, and then the nano composites. So with all of these, those fillers are they're perfecting them. They're getting smaller and smaller and smaller and stronger. So they're figuring out how to get the best of both worlds in these hybrids. And to give you that visual, you can kind of see here if we had a variety of filler sizes. So the first one in A is larger filler particles, so this would be stronger, but it wouldn't be as polishable. In B, our filler sizes are smaller, but in C, we've got a combination. So these are the hybrids. Where they're adding some large filler particles and some small filler particles to give us polishability as well as strength. Polymerization is the chemical reaction that occurs when the monomers of these resins join together and form these long chains called polymers. This reaction occurs with either chemical activated cure or with our curing lights, or a combination of the chemical as well as the light curing. 3 types of composite materials are used. The chemical consists of a base and a catalyst, and when mixed together, that initiates the chemical reaction. Like I said, the light cure is the most common. That's using a curing light only to begin that reaction. And then there's the dual cure that require both that base catalyst as well as the light. Flowable composites are going to be your low viscosity, so they don't resist flow, they flow easily. Typically these are light cured. I think of our sealants when I think of flowable composites. They can be lightly or heavily filled. That just makes them stronger and more durable. Like I said, pit and fissure sealants are the low viscosity. They can contain filler or they can have no filler in them. These are used to prevent dental caries in the deep pits and fissures of our occlusal surfaces in our teeth. We also have what's called the bulk fill composite. These were developed to speed up the placement process of composite restorations. If you remember, we talked that composite should only be placed at 1 to 2 millimeter increments at a time. That way we don't have micro leakage from the shrinkage that happens as they cure. These bulk fill composites are designed so that it will permit increments of 4 millimeters plus. So they don't shrink as much. They will, some of the challenges are the flow. Obviously, these are going to be thicker. So it's going to be hard for those to get into the deep voids and areas that we need where the more flowable composite can access that. Another challenge is to have acceptable physical properties and good aesthetics with good polishability. Translucency is also sometimes a challenge with these bulk fill. The filler particles have to be larger, and these are available in two consistencies. They can be either flowable or viscous nano hybrids. So they're improving these all the time, and if you are or have been an assistant recently, you've probably worked with these quite a bit. Packable composites are going to be highly viscous. So they're typically microhybrids, so they have smaller filler particles mixed with some larger, and they're thick and they have to kind of be compacted or condensed into the prep of the tooth. So there's a high volume of filler particles, and these are typically used on posterior teeth where we need things to be strong. Some of the heavily filled composites are going to be used for those buildups, those core buildups that go on top of those endodontic posts for a tooth that has been badly broken. So we need to build that tooth back up so that we can give it a crown, and the crown will have something that will hold it. If a tooth is broken really, really badly down close to the gum line, if you try to put a crown on a molar that's going to withstand a lot of chewing force, it's going to fall off constantly. It's going to be a chronic patient on you're calling you wanting to come in for a re-cement. So we use what's called these heavily filled composites. We place a core down into the pulp chamber, and then we attach that core to the remaining tooth structure as well as that post, and that will give us something to help retain that crown. And those can be light cured, self cured, or dual cured as well. Some of the physical properties of composites, again, anything we put in our mouth, we want to be biocompatible. We want our tissues to like it. We want them to be strong. We want them to be able to withstand wear. Typically, composites will wear faster than amalgam, but they're improving. That is one reason why amalgam is still the most commonly used restorative material in the United States. Polymerization shrinkage is something we want to always think about with composite resin. That's why we typically cure in those small increments so that we don't have too much shrinkage, with the exception of some of those bulk composites that they're making now that allow you to place them a little bit heavier. The carbon-to-carbon double bonds that have converted to single bonds during the formation of the resin polymer gives you that degree of conversion. That's nothing that you guys will be asked. It has to do with shrinkage. Thermal conductivity is, as we've talked about, the expansion and contraction of a material due to temperature. So composite resin has a thermal conductivity close to that of natural tooth structure, which is a really good thing. That is one of the benefits over amalgam. Amalgam is metal. As we know, metal is a good conductor of heat and cold. So it's going to expand and contract at a much different rate than tooth, where composite is much closer to the tooth structure. which would hopefully decrease our chances for percolation and possibly fatigue failure, micro leakage, things like that. That coefficient of thermal expansion is the number that we give to a tooth's ability to expand and contract. So the coefficient of thermal expansion of composite is greater than tooth, but not as great as amalgam. So even though it is closer to the natural tooth structure, anytime there's a difference over time, that expansion and contraction can lead to micro leakage. The elastic modulus is the stiffness of the material. This is determined by the amount of filler in the material. So the greater the volume of filler particles, the more wear resistant that material is going to be. Water absorption is the ability of a material to absorb water. If it's able to absorb water, it's also able to absorb stain, sometimes even odor, things like that. So the more resin there is in the content of the material, the more it's going to absorb water. Old composites in radiography, I showed you, especially in the anterior area, we would see they almost look like decay because they were very radiolucent. The material allowed X-rays to pass through it. So as time has progressed to make these more easily identified on X-ray, they've added little flecks of metals such as lithium, barium, or strontium to make that restoration more radiopaque on an X-ray so that we can identify that that is in fact a filling and not decay. Here are some images to show you how these may look. On the image to your left with the anterior teeth, you can see old composites, how they look very dark. And some of those could possibly have some recurrent decay under them, but we don't know till we get in the mouth and we look because we're not real sure what we're looking at. If you look at the image on the right, we've got on the lower right molar in number 31, that is composite. I would guess that the tooth above that, tooth number 2, is also composite. Number 3 has a porcelain fused to metal crown. If you look at number 4, it has an MOD amalgam. You can see how it is a more bright white than the composite material. But the composite material is somewhat radiopaque, so we can see it, but it doesn't show up quite as bright as metal does. So that's what happens when they add those lithium, barium, or strontium flakes to the composite so that we can identify it on an X-ray. We've talked about incremental placement and how important that is for micro leakage. We want to use moderately sized, or the incremental placement is used in moderately sized to large cavity preps. So an area of deep decay that has been cleaned out, we want to place small increments, not over 2 millimeters at a time, and this is going to minimize that polymerization shrinkage that happens as the resin cures. This will also allow for adequate curing all the way through. If you, with the exception of some of the bulk materials that they have out there, you want to make sure that we get a good cure and that we reduce that shrinkage as much as possible so that we don't have micro leakage or sensitivity with that tooth. Matrix bands are something that Professor Tresner will be showing you in our lab time. And basically, as you can see, this is a matrix band wrapped around a tooth, and they're going to fill that, I believe that is the mesial incisal of tooth number 8. And they want to hold that so it doesn't bond to the tooth next to it and completely fill that space. But we also want to have something to help give it the form that it needs to contour nicely next to the tooth beside it. So the matrix band creates that wall to hold in that resin. Wedges can be used for this as well. They are placed interproximally and they help to hold that matrix band against the tooth to seal the gingival margin and prevent any overhang. Overhang is where that material hangs out over the tooth or over the gum tissue and can create all kinds of gum issues where that's located. Typically these wedges are made of wood or plastic, and they can even be color coded like these are for size. Sectional matrix systems are typically used for class 2 composite resins. So this would be like an MO type composite. So we want to make sure that we don't allow that composite to again bond to the tooth next to it. We don't want to close off that contact area. We don't want an overhang. So we use these little clips, and the matrix band is silver. And again, you will get to see these up close and personal in our lab. Circumferential matrix is another type. These can also be used with class 2 composite resins. They are more difficult to use and require a heavy wedge for a good contact. Cervical matrices are these plastic matrices that you can see placed against this tooth, and they're available for cervical composites or glass ionomer restorations. So that would be like a class 5 composite or glass ionomer done right at the gum line. Factors that can affect the curing of a resin, especially with light curing, is the short curing time. If we don't utilize our light for the amount of time that the manufacturer recommends, sometimes we can get an incomplete cure. If the light is putting out inadequate light, that can cause an incomplete cure. If you're using the wrong wavelength of light with your resin material, that is obviously going to affect your curing. If we've incorrectly positioned our light, that light should be held about 1 millimeter away initially, and then almost in contact with the composite after 1 to 2 seconds. The tip should be positioned at a 90-degree angle to the composite surface, and the curing time should be increased if the light angulation is compromised in any way. So if you're unable to attain that 90-degree right over the composite, then you might want to go ahead and cure just a little bit longer. Anytime you're using a light cure, you need to have that eye protection on or be using a shield, because that light can damage the retina of the eye. So we want to make sure that not only ourselves, but our patients, and if they have someone in the room that's watching what you're doing, their eyes need to be protected as well. And you can see here they're holding the shield up, and they are curing at a 90-degree angle to tooth number 9, very close to the tooth. For composite repair versus older composites, new composite, like I said, is stronger. Finishing and polishing of our composites, you guys are next week going to learn how to do that in clinic on our typodonts. This finishes and corrects any irregularities in the contour of a composite. It will remove any excess composite material and smooth the margins to make them easier to maintain. Polish them will also remove scratches by applying a finer abrasive. We start with the most aggressive, and then we go finer, finer, finer until we use a shimmer paste, which leaves that glossy, smooth surface on our composites. Surface sealers are unfilled resins that are added to the surface of a resin after finishing or polishing to make them look nice and to protect the surface of that composite. Indirect placement composite resins. Now remember, something that is placed direct is done chairside in office. Something that is an indirect restoration is required to be taken to lab, fabricated in lab or outside of the mouth, and then brought and placed in the mouth. So there are laboratory processed composites, and some of the materials that are used for these indirect composites would just be the conventional composite material, fiber reinforced composite, or particle reinforced composites. These are delivered in an indirect chairside technique. outside of the mouth, but in the office. So it would be fabricated in a machine, kind of like CEREC crowns are, and it's almost like an inlay or an onlay. So you would take a prep of the cavity prep, and from that you would form the composite restoration, and then it is put to place chair side. The direct composite restorations are the ones where you actually put the composite material into the prep and it forms in the tooth as you're condensing it down into the tooth structure and curing it in increments. This would be fabricated in one piece and cemented to place. Glass ionomer cements have become very popular. The good thing about glass ionomer cements is the fact that they're fluoride releasing. So through the life of the cement, it is constantly releasing fluoride. These can be self-cured or light-cured. They bond to tooth structures directly without any bonding agents. That's another benefit. They can be used as luting cements, restorative materials, or liners and bases. A luting cement we'll talk about more when we talk about cements, but luting materials are typically mixed to a thinner consistency or a less viscous consistency. They are placed on the inside of a crown or an onlay or an inlay, and they're actually used to cement that restoration to the tooth. We can also do, many times these were used for class 5 fillings at the gum line because of their fluoride releasing ability. Liners and bases, because again they release fluoride, we can place them under a large filling, and we know that that would help with the potential of recurrent decay. The bad thing about glass ionomer cements is they are sensitive to moisture during the first 24 hours after they've been placed. So they're highly soluble during this time, and typically a dentist will cover them after their placement with a protective varnish to make sure that the moisture of the mouth and anything that you drink does not affect the filling, because they're very soluble. They'll absorb and dissolve in water. But after that 24 hours, they reach their final set, and that's no longer a worry. They are not very wear resistant. The other thing is they can't be polished to a nice smooth surface like a lot of composites can. So they do have a few drawbacks, but they have been wonderful for their fluoride releasing capability. A glass ionomer sometimes is sandwiched between the tooth and composite. So we're using the glass ionomer in this particular cavity prep kind of down by the gum line, and then we're putting composite resin over top of that. That gives us the benefit of the fluoride release, and then we've got the strength of the composite and the polishability of the composite resin on top. When two or more are used like this, two or more materials are used, they'll call that the sandwich technique, where they layer different materials. They have come out with hybrid ionomers. So these are glass ionomers that have been modified with resin material, and resin material is prettier. It allows those ionomers to be polished to a more lifelike look. So it does give them improved physical properties. It also gives them the ability to be dual cured. They are stronger, easier to polish, more wear resistant, but yet we still have that fluoride releasing capability. Nano-ionomers, again, the smaller the particles, the prettier they are. So these nano-ionomers, we've added the smaller particles that do give them more polishability, more lifelike look, improved aesthetics, but also provide wear resistance with our normal glass ionomers. And again, we still have that fluoride release. And then the Compomers are composite resins that have been modified with polyacid. These also provide that fluoride release and have light activation chemicals included in them as well. So again, this is another step up on the ladder. They just keep improving on these resins, making them not only stronger, but the fluoride release capability is better in some of these, and then the curing is improved. Giomers is the newest hybrid. This one releases fluoride at a slower, lower rate than glass ionomers. And they can actually be recharged with fluoride as you're using fluoridated toothpaste or a mouth rinse, such as ACT. It will actually act as a reservoir to kind of soak up that fluoride, and it keeps continuing to release it at that slow, low rate. These are typically packaged as single paste syringes or flowables. So when I went to the Missouri Dental Hygiene meeting last October, this was kind of the rage that they were talking about. So in summary, composite resins can be direct placement restorative materials, and they have a wide variety of uses. They're not just used for fillings. They can be used for sealants. They can be used for cements, like we already talked about. They can be used as liners and bases underneath other fillings and restorations. They have applications in all classes of cavity preps and many cosmetic applications as well. And the most important thing to your patient is that they are aesthetically pleasing and durable restorative materials.